So today we will be discussing on this topic, the value of a research paper in your name. So I think this was a topic suggested, that came up from your own discussions and your own interest. So let us see what, being at a slightly, a few more years ahead of the curve in that sense, from where you are at this point, what I can share with you about my experiences with research and communicating research. So thank you very so this is what we will try to go through. I will just give you a brief background of what we intend to talk today, and then start with why should we write and how the process of writing or research as a clinician scientist evolves, how we measure the impact of our research, what are the benefits, both the tangible and the intangible ones, and what is coming back to the main question of what is the value of research or a value of a research paper in your name. So I just wanted to tell you briefly so that we can put all these things in context. So I am basically a clinician. So I did my schooling in Kerala, and then I spent 2 years as an international scholar in Singapore. I came back and did my MBBS at Amrita Institute of Medical Sciences, Cochin. Following that, I did my MD in internal medicine and DM in neurology from PGI Chandigarh, and then a postdoc fellowship in movement disorders from Sri Chitra. And after that, I have been working in faculty positions, initially at Sri Chitra and then now at AIIMS New Delhi for the last about 4 years. So I am telling you this just to set the background for our talk. So I will be talking about the value of a research paper from an early career researcher's perspective. So although I might come from, dinosaurs' time compared to you young ones there. But in terms of research lifetime, I am still an early career researcher, probably transitioning into an intermediate or a middle career researcher. So I will tell you the value of research from an early career researcher's perspective, and more importantly, from a clinician scientist perspective. That is important for us because our career paths and our choices and the kind of research that we do may slightly differ from core, basic science research, which in many parts of the world, there are options to do MD, PhDs, where you can spend some time, delving into core basic science research. But in the Indian system, it is sometimes difficult to take some time out for, a core focused research career like that. Although there are institutes and there are places that offer that kind of options. For example, NIMHANS has a PhD program after MBBS. AIIMS also has a PhD program after MBBS. But those pathways are different. So I will be speaking to you from a practicing clinician scientist perspective. So how did the research journey went? So for all of you, if you think back now or you think ahead, you might be able to identify a time. So for me, I think my interest in research started somewhere around the time when I was, doing my 11th and 12th standard A-levels actually in Singapore. So I always think about this experiment that we had to do as part of our physics coursework, and this was an exam in which we used to have a test called, you have to design an experiment and perform it. So this you can see is basically, this was a physics experiment in which you are given a projectile. I think it was a small, lead ball or something, which you had to roll it. You must have done this in your classes, I'm sure. So you have to roll it down a slide, and depending on where it lands at the bottom, you have to measure that, the distance traveled, and then calculate the value of G. So as we all know, the value of G is 9.8 meter per second square. So the problem was that when you do this experiment, you'd have to do it multiple times, plot a graph, and then, find the value of G. The value of G that I was getting from my data was nowhere near 9.8 meter per second square. I think I got something like 1.5 or, 2.8 or something like that. So it was really very hard for me to, I obviously I was failing. I was supposed to find the value of G, and, you're not getting there somewhere. So many of my smart friends back calculated. So we all do this sometimes. So, obviously G is 9.8. So you can back calculate from that equation and create a graph, and of course present it as the work that, that you have done on your own. So this is what many of my friends did, and I was very disappointed and expecting a very low, mark when in this particular experiment when the results came. And I was surprised to find out that I managed to score much better than the people who had calculated the value as 9.8. So this was because there was some twist. The teacher had put in a twist in one of the equations, in that we were supposed to get a graph with a negative slope, whereas those who back calculated got a graph with a positive slope. So the teacher could make out who has actually used their own data and who hasn't. So this is one experiment or one test that always remains in my mind and reminds me before we start any discussion on research that data is sacrosanct. So we should that is our starting point. So when you do an experiment, your results may not come up as you expected, but it is important to honor that data, believe in your data if you have collected it properly, and then try to explain why your results were different, rather than try to fit your data into the result that you expect. Right. So this is somewhere where I started. I feel that I started my interest in research, and the simple reason for why we should write about research, why you should have a research paper, is basically to communicate your research. So that brings us to the question. So the major question here is, why research? Why should you do it as a medical student who is a clinical, going to be a clinician, or a non-clinical involved in patient care? So why should you spend your time in research? So how do you start? So you could say that I am a late starter, in the sense this is probably my only publication from my undergraduate times. But I have to really thank Professor Vasudevan sir for this. So when I joined Amrita as a first year medical student, and I met him, and I was really interested in taking up some kind of research, and he guided me to Professor Balakrishnan and Dr. Ilango, so in whose labs I could do a small summer project in which we looked for hepatitis G virus among chronic liver disease patients and blood donors samples. So this was a very good learning experience for me, in the sense I learned the techniques of RT-PCR. I did it myself. I got some help to analyze it from Dr. Ilango. And then finally, I was able to present this at a meeting in Kuala Lumpur. I think it was the Infectious Disease Society meeting that year. So this is how I started. So this would actually be under the realm of an original research. But there are some other easier ways to start off. So this would be a normal progression that one would expect from in a clinical scientist career. So the initial things that you write about are like case reports, letter to editors, and review articles, like a narrative review. And then you gradually progress on to writing original articles, conducting them, experiments and writing them, reporting them, and meta-analysis. So case reports. So these are just to show you some of the case report means. I'm sure that I hope you have started your clinical training. So you will come across definitely many interesting patients who may have a rare diagnosis, or it may be an uncommon manifestation of a common disease. So these are the patients in whom you can work up in a bit more detail, review the existing literature, and find out how your case is novel and what does it add in terms of knowledge or as a learning experience for other clinicians. So like that, these are some cases that we had reported throughout the years. I would like to specifically talk about this one, which was a case series, which is we do in Parkinson's disease a kind of surgery called deep brain stimulation for patients with advanced Parkinson's disease. And then we reported this complication of DBS. When it suddenly stops, patients can go into a malignant syndrome, like neuroleptic malignant syndrome, and come to you as a movement disorder emergency. And although this was a very humble case report, and it was published in a very normal journal, impact factor maybe about 1 or so, but this was an important observation, and that journal actually took out an editorial for this article. So and even case reports can actually give you a lot of meaningful information, and can be a good exercise in assessing how to do a literature review, how to write, and how to get it submitted, accepted, revisions. So this is a good starting point. Case reports. The next one is letter to editor. So letter to editor, there are two types, as you may be aware. So sometimes you can write them as a new letter, as in a new observation can be put as a letter to editor. Sometimes, like we have done in this case. So this was an article published by a team from, I think, Korea, about thrombolysis, which is a treatment we give to patients with acute stroke, and safety of this thrombolysis in people aged 80 years or above. And so this, we wrote a reply to this article. So letter to editor can be, correspondence can be, you can criticize this article, or you can point out new meanings or new dimensions to that article, or you can sometimes interpret that article in terms of your own patient data. So that is what we did here, that we also had a similar patient about whom we, our experience, we wrote about it as a letter in reply to the published article. So this is a very good exercise for each and each one of you at whatever stages of your career you are. So there will be the major journals will have randomized controlled trials and large cohort studies. So it would be a good opportunity for you to review. And this is something, if you do journal clubs as part of your research club, this is something that you could take it up on a regular basis. So whichever journal article that you discuss in your journal club, the person who is presenting can summarize the salient points on critical appraisal of that article, and it can be written back to the publishing journal as a letter to the editor. So this also helps you learn skills of how to write, how to review literature, how to critically review another article, which helps when it's time for you to write your own. And then you have review articles, right? Review articles are another easy starting point, which this you must be doing on a day-to-day basis without thinking much about it. When you see a patient in the ward, if it's a first time you're seeing that case, or if there is an interesting therapeutic dilemma there, you will be reviewing the literature. So the classical traditional review is now called a narrative review. Narrative review means it is not a systematic search of all the available evidence databases, right? So this is maybe a little bit biased in the sense your own impressions or your own experience may color your judgment when it comes to a narrative review. But still, it is a good starting point for us to understand the state of the field that you're looking at, and to sort of summarize succinctly the evidence in that field. So this was one of the review articles that we wrote in, I think, 2016 about, this is again, because I am into movement disorders, most of these articles would be movement disorders related. So this is about cortical plasticity in Parkinson's disease. So we had summarized the evidence from a lot of transcranial magnetic stimulation and transcranial direct current stimulation studies into how the brain plasticity affects levodopa-induced dyskinesias in Parkinson's disease. So case reports, letter to editors, and review articles. So these, I would group them in one category. So these are the things that we as a starting point that we can do without effort is the same. I mean, I don't think that writing definitely always takes a lot of effort, but without any additional sources of funding or manpower or equipment, these are things that we can do as part of our clinical responsibilities, right? So, but the next major group is what I am interested in, and I hope that you also are interested in, is original research. So that is slightly different from the ones that we discussed so far, the case report, case series, letter to editor, or the review article. Original research means, first of all, you should have a research question. And then you should, work out a testable hypothesis based on this research question. Then you have to design an experiment based on your research hypothesis and execute it, and then collect the data, analyze it, write up, and publish. So this is a different scheme of things from those that we have discussed so far. These don't come into play for a narrative review or a letter or a case report, right? So original research the most important thing is to have a research question in mind, and the value of the paper that you bring out of research depends on your research question. So I will be focusing on this throughout my talk, because if your question is not valuable, it is very difficult to make a valuable paper out of it. So unfortunately, most of the time, I have also learned this from the hard way. Everybody learns it the hard way. Sometimes questions that seem interesting or easy to do for us, at the end of the day, you find it very difficult to publish it. That is because the value. So always keep the value in mind. So the value of your research paper depends on the value of your research question. By that I mean, what value is it to the scientific community, to your patients, to the society? Do they see a value in it? Is it adding something? That is the most important thing that makes your research valuable, the research question, right? So in original research, I must say that for me, at least personally speaking, mentors have been very important in guiding you your research. So as I spoke earlier, Vasudevan sir was at Amrita when I was a student there. So he has been a great mentor. And then when I moved on to do my MD in Chandigarh, I was fortunate enough to be allotted to Professor Vivek Lal, who is currently the head of the Department of Neurology at PGI, as his thesis student. So that I would say that is where my interest in original research began. And I say the role of the mentor is important because at the initial stages, it is through them that you develop your interest. For example, I knew that I wanted to do neurology during my MD times, but Professor Lal's fields of interest were basically neuro-ophthalmology and headache. So when I approached him for a suitable thesis topic, it is only natural that he suggested some topics. He didn't suggest a topic, he suggested the overall area that you think about working in migraine. So if you know about migraine, there are many things that, as an MD thesis, one can work on. Like you could look at the clinical features of migraine. You can, think of subtypes, migraine with aura, without aura. Is there a difference in some parameter between these patients? You can look at the pathophysiology of migraine. You may be able to do some work on genetics of migraine, and then you may be able to look for some associations, migraine with other diseases. So this is how you generally thing, and this is what was, these were the things that were going through my mind when I also searched at that time. I think this was in 2009 when I was looking for a thesis topic. I read widely migraine, what is the current, what are people doing in migraine, and through those review and that reading came up this idea, or this I noticed this association that migraine is not classically a very strong risk factor for stroke, but especially in patients with migraine with aura, it has been shown that it's a very, very slightly increased risk of stroke in these patients. And many times, if you have a migraine and you get an MRI of the brain, you see many white matter, non-specific white matter changes, which are suggestive of maybe some small vessel involvement. So this association sort of caught my interest. What is the association between migraine and stroke? So we began. Then I discussed with my mentor, and this was my MD thesis. During my MD time, we thought, if there is stroke and there is migraine, is it that there is a prothrombotic state in migraine? So that could be because of various reasons. It could be shared genetic factors. There are some hereditary thrombotic states. Maybe those genes have something to do with whatever putative genetic basis for migraine. So we searched for prothrombotic states in migraine patients. So we did a cross-sectional study. I recruited some 101 patients with migraine and 148 controls. And in them, we looked for these prothrombotic factors like protein C, protein S, antithrombin 3, factor V Leiden, APLA. These are antibodies, antiphospholipid antibodies, anticardiolipin and anti-beta-2 GPI antibodies that can all cause a prothrombotic state. So we screened these patients and controls for this, and we found out, unfortunately, I was very sad when the results came, that the traditional prothrombotic states were not different in patients with migraine compared to controls. And this is what you learn as you go through this. And now I'm looking at this paper. Does anybody see anything wrong with it? So we have used the term prevalence here. So this term is actually, it's not the right term to use there. It's frequency. Prevalence can be calculated only from population studies, not from a hospital-based study like this. But see, it went through, we did it, we wrote it, it went through reviewers, and it's got published. So somebody could have written a letter to editor at that time pointing out this deficiency in this paper. But we found out that overall the results suggested that it was not because of a prothrombotic state. So then this is how one research question begets another research question. So came the time for my DM in neurology in the same department with the same professor as guide. And so I read a little higher level of reading about it's not a prothrombotic state, what else can it be? And then there was the concept of endothelial dysfunction, right? You might have heard about it, that there is this concept of endothelial dysfunction, which has been implicated in many thrombotic and other diseases. You can measure both systemic endothelial dysfunction, you can measure easily with the help of something like a BP apparatus, a cuff inflator, and an ultrasound probe. So you inflate the cuff in your brachial artery, and then you measure the brachial artery dilatation after you release that cuff. Right, so this is called flow-mediated dilation of the brachial artery, brachial FMD. So that is a very standardized technique for measuring systemic endothelial dysfunction. For cerebral endothelial dysfunction, we used a similar technique using transcranial Doppler. So we used a transcranial Doppler and measured the endothelial function by asking the patients to breath hold. So when you hold your breath, CO2 increases, causes vasodilatation. We can measure that using transcranial Doppler. And then we saw whether there is any endothelial dysfunction in these patients with migraine. So interestingly, we found out that they have no systemic endothelial dysfunction, but they have some cerebral endothelial dysfunction, which is localized to the posterior cerebral arteries, the basilar arteries only, right? So basilar and posterior cerebral arteries where significantly the breath holding index was impaired in patients with migraine compared to controls. So so this was a finding, a reasonably novel finding at that time, which was why it got published in a good journal. JNNP is a good as an impact factor of about 7 or 8 and one of the good journals in neurology, in the field of neurology. So and it has been subsequently confirmed by other people and other studies validated. So this was how. So this, I just wanted to show you this, that your initial research interests are often guided by the mentorship that you receive at that stage. And one research question often leads to another research question. So we should not, it should take it as a good opportunity if the results come up contrary to your expectations, because it provides you with an opportunity to do something further and go more deeper into that field than otherwise you would have done, right? So this was my body of what work that we have done in migraine, because after that I moved on to movement disorders. So towards the this came because towards the end of my neurology 3 years, I had realized that my interests were going towards movement disorder. So movement disorder is a field, subspecialty of neurology that deals with diseases like cause movement problems, right? Like they can be hypokinetic, means a lack of movement, like Parkinson's disease or a typical Parkinsonism, or it can be increased movements, hyperkinetic, like dystonia, tremor, chorea, right? So, and this is a field that has many unsolved questions, and even now heavily dependent on clinical diagnosis. So for example, if you have a patient with stroke, you can do an MRI or a CT scan and you will see that there is a stroke there. But for a patient with a Parkinson's disease or dystonia or tremor, you have only your 2 eyes and your brain. You have to see it and then you have to decide whether this is tremor or dystonia and chorea. So it's a clinical diagnosis, and therefore, as you will see a little later in a few more slides, that it is not very easy. It is not often easy, not just for young people, trainees, but also even for experts. It's often not easy to come to a consensus diagnosis. And this is also a field where now there are exciting new therapies that have come up over the last decade or 2 decades, like deep brain stimulation, which is a pacemaker insertion for the brain that we do for patients with advanced Parkinson's disease or dystonia to help them control their symptoms, and strategies like botulinum toxin injections. So there are new therapies for symptomatic control of these medication for these diseases, but there is a huge bench to the bedside gap when it comes to disease modification, or cure, or a meaningful disease modification of these diseases, right? So there are symptomatic therapies which are very exciting as a clinician to use, but still a huge gap if you think of your goal is to cure PD or dystonia. A lot that we don't understand about these diseases. So this is a field with many unsolved questions. So, which is probably why I sort of got drawn to this field. And I just wanted to let you know that once you are in a, in working as a clinician, this is one of the strengths of being a clinician scientist, because it is clinical experiences that drive research for us. So this is a bit different for. And we are fortunate to be able to have these experiences, because these are the things that generate the research questions in our mind, and therefore I feel that those questions are more easily translatable or more easily relevant to the patient than if we were doing a pure lab-based research. So our strength is in our research question. So for example, let's see this patient. This was a 45-year-old gentleman who I saw when we were in Sri Chitra. He had Parkinson's disease for the last 4 years, and he was being treated with levodopa carbidopa and a dopamine agonist drug, which is pramipexole, right? So he was doing very well, but for the last 4 years, over the last 1 year, he has started buying lottery tickets excessively, and progressed on to online gambling. And he's been putting in a lot of money in this. Was a businessman, had losses in lakhs, and all the savings have been depleted by the time the wife and others came to know about it and brought it to our attention. So do you think this is a medical problem, or is it something to do with not related to his Parkinson's disease? So this is a problem that we may see in patients with PD called impulse control disorder. Right. So these are impulse control disorders, which are a non-motor symptom of Parkinson's manifestation of Parkinson's disease. And this gentleman here has a lot of risk factors that put him at risk for it. So it is usually seen in younger people. He's 45. And its strongest risk factor, one of the strongest known risk factors, is this drug called pramipexole. I mean, dopamine agonists in general. So these drugs may sometimes induce these impulse control problems, by which I mean they may get, compulsive shopping, there's pathological gambling, hypersexuality, compulsive eating. So these are, even any of these symptoms are there, and they are disabling enough to cause trouble in their professional, social lives. We call that impulse control disorder. So this person had an impulse control disorder. So when you see them, it is only natural that the question comes in your mind, why did he get it? So we know that, okay, he's young. He has been on a pramipexole, dopamine agonist, but not everybody on dopamine agonist develops it, right? So there may be some other individual risk factors. So this generates a question in your mind. So why do some patients develop ICD? So these are the known risk factors, like personality traits, maybe genetic, depression, smoking, alcohol, early onset Parkinson's disease, dopaminergic medications. These are all strong risk factors. So from this comes the research question, that what are the factors associated? Why do some patients develop ICD? So this was a study that we did in a cohort of patients who were at Sri Chitra with Parkinson's disease and had impulse control disorders and did not have. So we did a cross-sectional, case control study looking for variants in the dopamine D3 receptor gene. So this is a serine 9 glycine variant, which is a functional variant. Means it is a function enhancing variant in the dopamine D3 receptor. So patients with this variant have a higher affinity receptor for dopamine, and this has been in some previous data in some other populations. It had been shown to be maybe correlated with ICD. So we checked that in our patients, and we found that a particular genotype was associated with ICD in Indian PD patients, and this was a novel association. So when you know that we don't stop there, right? So so it is, how does this gene cause this, right? We know that this gene is associated with ICD, but how did it cause it? So there may be other patients with this gene who don't have ICD. So do they have a pre-ICD any problems? So to look at that, what we could do is to look at PD patients without ICD, without active ICD, and then test for impulsivity in them, right? So impulsivity is a psychological trait. that can be assessed using some tasks, like the Iowa gambling task is one. So this is a it's quite a kind of a, it was a fun experiment to do, I must say. So you have these you have the software that has this Iowa gambling task, and then you have to teach the patients. So it's like basically like a card game. So they have to choose from 4 decks, and when they choose some decks, they will get a reward, and sometimes from a deck they will get a punishment. I mean, they will lose money, and they have to sort of learn which are the decks that are least risky. So they stick to the less risky ones, but small gains, they are eventually likely to make more money than if they make a lot of risky choices. So you can assess their risk gain sort of profile using this task. And we checked whether this was affected by the genetic variant that we had found in ICD patients earlier. So when we compare that, the main outcome, the money that they made in the task, or the score, total score, was not significantly different from the groups, but between the groups. But we found that their pattern of choosing the deck, see, deck A, B, C, D, was significantly different between groups with the functional serine 9 glycine variant compared to patients without that. Right. So this sort of implied that probably this variant does enhance the impulsivity in a subtle manner. And when then these patients are exposed to other factors like the dopamine agonist, and it happens in a young patient, then probably it is manifest as an ICD. So that was again probing into ICD and impulsivity in a little deep. Then again, once you do so, again, once you find this, your questions don't stop there, right? So if pramipexole does, what about other treatment modalities? Does treatment for PD influence impulsivity? So that is the next question that comes, right? So in this diagram, you can see this is what we do in deep brain stimulation, right? So this is a like a pacemaker. This is a neurostimulator. So this, you can see, is the subthalamic nucleus here in the brain. On both sides we have one each, and the subthalamic nucleus is the target where we put these electrodes during deep brain stimulation surgery, and then these electrodes are collected by a lead wire extending to the pacemaker, and then we give current, I mean electricity, and then sort of control the motor symptoms using this stimulation, and while reducing the medications used to treat for PD. So this is the standard of care for advanced Parkinson's disease patients who have some complications from their treatment called motor complications, called motor fluctuations and dyskinesia. So this is the standard of care that we do. But this process, we wanted to know, because STN is an important nucleus for decision making. We know that from a lot of existing data. So, and there are reports that PD patients may sometimes develop ICD after STN-DBS. Whereas most patients who had ICD, it resolves after STN-DBS because we reduce the medications. We can take away the pramipexole, for example, and then the ICD evolves. So does STN-DBS enhance impulsivity? Was the question that we wanted to ask. And we did this by assessing the impulsivity before and after STN-DBS in a series of patients while keeping the dopamine agonist medications constant. Right, so this helped us. So this paper is again, it showed like it was seen in the earlier paper, the overall outcome was not different before and after STN-DBS, but their deck choice patterns and choosing over a series of blocks was different between patients before and after the DBS. So this is how you could you could use research to understand what you're doing in your clinical practice better. Right. So there are no dearth of questions to probe. As you can see, once you start, so far I talked to you about during my neurology and MD training, how we worked on migraine, and then the series of papers on impulsivity, non-motor symptoms in Parkinson's disease. So there are no dearth of questions. So from this one paper, you can easily ask another question to another. But for to continue this, you need resources. So all the work that I showed you so far are all non-funded. It was TM thesis, MD thesis, or as part of ongoing projects in the department, it was done. So, but to continue this on independent basis on your own, you need resources. You will need funding, you will need manpower, you will need some equipment, and most importantly, you will need time. So for this, you gradually, if one is serious about research, one has to gradually gravitate towards funded research projects. So let me tell you, because again, a lot of this, let me show you these 3 videos. Okay. So this, I hope the videos are playing. Please let me know if you can't see them. So this is you may have seen in your clinics, this is a classical patient with a rest tremor. You can see the arms are nicely at rest, right? And he has a rest tremor at the both the hands, but right definitely much more than the left. So this is the asymmetrical rest tremor of a classical Parkinson's disease, right? So this is another patient who has another kind of tremor. Now this is a postural tremor. It's kind of a little faster than the PD tremor. And you can see that the hand is not completely straight. See the position when it stops, it is a little flexed, and wrist is flexed, and the fingers are also. So, and when he writes, he has a lot of dystonia, writer's cramp when he writes. So this is a patient who has a dystonic tremor. The dystonia is not very apparent in this video, more when he writes, but this patient had dystonic tremor. And then you have this another patient. So it looks almost similar to the second patient, right? She also has a postural tremor. But you can see it is much more, it is asymmetrical but bilateral, right? And the dystonic posturing, she didn't have any dystonia on writing. And even on this extended hands, it is very subtle, not much. There's a little bit of flexion here. Dystonia means an abnormal posturing. These fingers are little extended, so not too much dystonia. So we would call this patient essential tremor plus, right? So now you can see these 3 kinds of tremors. The Parkinson's disease tremor, it is easy to pick up. It is a rest tremor. But between this dystonic tremor and this essential tremor plus, the differences are not too much. I mean, severity is different, but there is a, it may not be that apparent to many people. And even among experts, their agreement is poor to say whether this is dystonic tremor or essential tremor. So this is a conundrum that we face as clinicians daily in the clinic. When a patient comes with tremor, like the second and the third patients, we have to decide, is this a dystonic tremor? Is this an essential tremor? Why should we decide? Because essential tremor usually responds much better to treatment. If it is medications, if they are medication refractory, they respond better to DBS than dystonic tremor. If it is dystonic tremor, maybe we can offer him botulinum toxin, right? So the treatment decisions are dependent on your diagnosis. But when it is a clinical diagnosis, the pitfalls are that the reliability of a clinical diagnosis is often very poor. So this is a classical example of 6, or I think there are 6 blind men or women trying to describe an elephant. So depending on what they see, they would call it different things. So same applies to clinical diagnosis, especially in movement disorders in conditions like tremor. Even experts have only fair to moderate agreement on the diagnosis. So this is a very nice paper by Fair and et al. That appeared again in JNNP, in which they looked at the agreement between experts, movement disorder experts and non-movement disorder experts, for a diagnosis of Parkinsonism, for diagnosis of dystonia, for diagnosis of ataxia, for diagnosis of tremor. And this is the inter-rater agreement. As you can see, the inter-rater agreement at max reaches a moderate agreement. None of them is even good, even for the experts. So the clinical diagnosis, one person seeing a patient may diagnose it as essential tremor, another person may diagnose it as an essential tremor plus, another person may diagnose it as dystonic tremor. So the reliability is poor for a clinical diagnosis. This is the same thing that we saw in our cohort of patients when the Movement Disorder Society came up with a new classification for tremors to improve, diagnosis and classification. We tried to apply that on our patient videos, and we found that again, the inter-rater and the intra-rater agreement was at max fair to modest and not better than that. So instead of, so in the clinic, so this is a question that came from your clinical practice, right? You see these patients every day, you want to diagnose them. How do you diagnose them? So you need an objective biomarker. So that biomarker should be ideally reliable. That means if you use it, a second time, a third time, a fourth time, it should sort of provide you with the same kind of results. It should be valid. It should be actually measuring what it is supposed to measure, and it should be easy to apply in the clinic. So what kind of a biomarker can we use for tremor? So this is one of the things that people have been using for ages. This is what we call an Archimedes spiral. You can see the spiral drawing that a normal person would draw like this. Somebody with Parkinson's disease, the spiral becomes smaller, and the distance between the loops becomes narrower as they keep drawing. Essential tremor, tremors, and dystonic tremor, right? So these are spiral drawings which have been used in the clinics for many. We also use it on a day-to-day basis to assess, especially patients with essential tremor. When you treat them, you can ask them to make a drawing before. The next time when they come after treatment, you can ask them to make a drawing again, and you can compare. Keep the tremor has, does it look better? Does it look worse? Does it look the same? And sometimes it can help you to distinguish also, like a patient with Parkinson's disease will make smaller spirals like this. Somebody with ataxia will make bigger spirals. So some features may help you identify the disease as well. So for quantification and characterizing. So this could be a useful objective method. But the problem is that so far, most of the places or centers use only eyeballing for this. The expert looks at it and says, okay, this looks like PD. Okay, this looks like ET. Okay, this looks like it has improved. So that, as we saw from the videos and the paper after that, that the reliability for an expert judgment is not that great. So why should we, we shouldn't be relying on that. We should have an objective method to quantify and characterize this. So there are tablet systems available that do this. They exist. You can, the tablet with there are tablets with a software in which you can draw, and then they can quantify the amount of tremor or the variability. Those things can be measured. But we wanted to make a system for pen on paper spirals, because for us in our setting in the clinic, or for example, if you want to do a large scale survey, epidemiological survey, it is much easier and cheaper and feasible to use pen on paper rather than tablet based system. So we wanted to develop an automated spiral analysis platform for pen and paper spirals. And this was a funded project from the DST SIR. So this question again came from the clinic. So how to diagnose these patients? So and how to monitor them. So we in this project we included patients, participants with upper extremity tremor, essential tremor, dystonic tremor, Parkinson's disease, and healthy volunteers, and asked them to draw a freehand clockwise spiral on paper with the dominant hand. You can see the image there. So they are just given a plain paper with a 15 into 15 centimeter square and a central dot from where to start the spiral. And once they draw it, then we developed this sort of algorithm where we would scan the original image. Then it will go through some pre-processing steps. Like this is the original image. Then we will do edge detection, detecting the edges, filtering, smoothing. And after that, you will get an image like this. And these are images in the radial coordinates, and this would be converted from the Cartesian coordinates. We will convert it into a polar coordinate system. That is, we will unravel the spiral. So this will be the ideal spiral. If you unravel, it should look like this red line. But when you unravel the spiral of a handwritten spiral, this is how it would look like. And then we would fit it with an ideal spiral, calculate the deviation from the ideal spiral, and calculate the standard deviation and mean of that, and then identify also some other variables like a loop-to-loop distance. So we sort of wrote my research. So obviously I don't know coding. So I collaborate with I had a research fellow who is a MTech in biomedical engineering, and he wrote the code. I would how we wanted to develop this. So, and from that code, once you run the algorithm, this is something how it would look like. So this would be the ideal spiral, and this was what a patient spiral would look like, and this is what a control spiral would look like. And then we calculated some variables like tremor variability and mean deviation, and we found that both tremor variability and mean deviation were significantly different between patients and controls. And among both of them, TV was the better parameter to detect tremor. And we found a cutoff value using a technique called receiving operating curves, which is a statistical method for a diagnostic test. We can identify the sensitivity and specificity of it to detect tremor. Then we've also validated this with a lot of clinical rating scales and tremor, electrophysiological tremor analysis. And but as I already mentioned a few minutes back, results are not always what you expect, right? So this algorithm could detect tremor, it could quantify it, but it could not really distinguish between all the different types of tremors, which is what we wanted to do, to differentiate DT and dystonic tremor and essential tremor. So those are the limitations of a conventional algorithm. And therefore, then it was time for us to look at a new approach involving artificial intelligence. So then we came up with this project for Spiral DX, an AI-based approach to tremor diagnosis and quantification. This has been approved by the DBT. So we will use our existing database of spiral data that we already have and conventional machine learning approaches as a pilot effort. And then we are doing an ongoing prospective multicentric large cohort involving all these institutes, AIIMS, Sri Chitra, NIMHANS, IIT Delhi, and Caltech in the US, for using deep learning approaches on these spirals to see whether we can sort of distinguish what kind of tremor it is from the hand-drawn spirals. So the major question again now comes as a clinician: how does this affect my clinical practice? So far I have talked to you about migraine pathophysiology, some non-motor symptoms in Parkinson's disease, some pathophysiology, and how to differentiate tremor. But as a clinician, our aim is to treat, right? So how do you do research that impacts evidence-based medicine, that contributes to the pool of evidence that you use for your day-to-day clinical practice? So for level 1 evidence, as you know, comes from randomized control trials or a meta-analysis. So you could do those two. So this is something that I was involved in over the last maybe 2 years. So when we see these tremor patients, naturally you want to treat them. And especially for dystonic tremor, most of them are medication refractory. Many of them don't afford DBS, and outcomes of DBS are anyway not as good as essential tremor in them. So botulinum neurotoxin injections, Botox injection, Bont injections have been used for other kinds of tremors. For essential tremor, it has been tried. In Parkinson's disease tremor, there are 1 or 2 studies. So we thought, why not use it in patients with dystonic hand tremor? So far, there were no randomized controlled trials on this, only retrospective case series, which showed a reasonably good benefit. So we did this, asked the question whether botulinum neurotoxin injections are effective in treating upper extremity dystonic tremor. And we conducted a randomized control trial with 2 groups, parallel groups. We gave botulinum toxin injections to 1 group and placebo injections, normal saline injections, to 1 group. And this group's 30 patients were randomized into 15-15. And there was a mean difference of 10 units, 10.9 units, which is a clinically meaningful difference on the tremor rating scale between the Bont and the placebo groups 6 weeks after giving botulinum toxin injections. That means botulinum toxin helps reduce tremor severity in these patients. So in patients with dystonic, upper extremity dystonic tremor, EMG guided individualized Bont injection. These are some terminology that would tell you how we gave. So these injections were not just blind injections, they were EMG guided, and the dose and the pattern of injection was individualized for the patient's tremor. And these were beneficial for achieving tremor control without unacceptable hand weakness. Hand weakness is the side effect of botulinum toxin. But when we used EMG and gave individualized doses, and did not result in any unacceptable hand weakness. So this is I just talked to you about this study. So this was funded by an AIIMS intramural research grant. And we just completed it in March, and this paper is now under review. So you can see this is how the blue is the Bont group and this is the placebo group. So this is the total tremor rating scale score. So you can see the placebo group did not improve, while the Bont group, after receiving botulinum toxin injections, they have improved at 6 weeks and also at 12 weeks. So this is how you can contribute to the pool of evidence in your own field by doing these kind. And this is possible. It is feasible. We did it with much limited. This was not in any way industry sponsored or pharma sponsored. It was just a small funding from AIIMS, but we had manpower and people who were interested in doing it, and patients who were also interested to be part of it, and therefore we could do it. And then how to impact clinical practice other than randomized control trials. Another thing that I strongly urge all of you to take an interest in it from this stage onwards is systematic review and meta-analysis. So as we said earlier, a narrative review is not considered as part of an original article spectrum, whereas meta-analysis and systematic review, there are ways to do it. In the methods, I'm sure it might have been discussed in your previous lectures, how to do it. So this was a systematic review and meta-analysis of integrated care in Parkinson's disease. So integrated care means Parkinson's disease, it is like a patient's, it is a journey of a lifetime for a patient, it is going to be with them. So as a doctor, there are only some things that you can do. You can treat it, you can give medications, but they need a lot of other interventions like support from physiotherapy, speech therapy, right? So in the Western world, this is all part of normal care. And adding those, does it actually make a difference to the patient's lives? Is it worth the cost and the time and the manpower investments that you make for providing care, integrated care? So we reviewed all the published literature on integrated care models in Parkinson's disease. So we can see these are the so this is one of the results diagrams where we found we enumerated who all were involved in the care of PD patients, like movement disorder specialists, neurologists, nurse, physical occupational therapy, speech therapy, clinical psychologists in each group, how they were represented. And then we did a meta-analysis of available randomized controlled trials on this topic to find out whether integrating care, putting the effort for doing that, does it actually improve outcomes. So we found a small 0.17 is a small effect size, but a significant. So it is a modest but significant effect in favor of integrated care on the quality of life of PD patients who receive integrated care versus standard care. So if you have a team of people looking after these patients, the quality of life tends to be better in these patients, and that from the available randomized control trials, the effect may be modest because many of these trials, there were significant trial design issues. They were heterogeneous in different parts of the world, different health systems. So, but definitely in spite of that, we found that this definitely favors integrated care in terms of quality of life of Parkinson's disease, improving quality of life in Parkinson's disease. So meta-analysis is, again, it is something that needs a lot of time from your side, but may not require much in terms of manpower, equipment, funding. You have to identify a question, learn about the methods, and you can apply it, and that is how you can contribute to the evidence in your own chosen fields. So I would just wanted to end up with this paper, especially because this was this is the image from the same paper, Integrated Care in Parkinson's Disease. So we did a worldwide review, in the sense there was no geographical restriction, but I just wanted to show you that how much work is left for each one of us to do. So this is how the number of papers, you can see in North America, the European countries, Australia, even China is represented. India is in the 0 category here. So there are many centers doing excellent work in Parkinson's disease, but we have not been writing, or we have not been researching, looking at it in an academic aspect. So therefore, a lot of work for us to do here. So I just wanted to put this picture. This is in a supplementary information of that paper, but I just wanted to show you how underrepresented we are and how we should all be working gradually to make our data also much more visible to the world. So now you must be thinking the talk was on the value of research paper. So far I have been talking to you only about what we have, how it has, we've been evolving. So that is only because I wanted to tell you that the value is in the journey, I feel. Because to measure the impact of your research, definitely there are ways like this, impact factor of a journal. It is basically impact factor would be the number of citations that an article the frequency in which an article can expect to be cited in that particular journal. Then you can look at the number of citations. An H index, it can be there for each author. So if an author, it is the value, the maximum value of H, in that if an author has published H papers and they have been cited H times, so that value would be your H index. And I-10 index would be if you write a paper, number of papers that have more than 10 citations. And now there is also a lot of talk about altmetric scores. Altmetric score is now for social media visibility of papers and research. So these are formal ways to measure the impact of your research. And then there are some other tangible benefits. Like for me, I can say I have learned a lot of technical skills from the research projects that I have been involved in. I learned how to run a PCR. I have learned how to do neuropsychological assessments. I have learned how to do FMD, how to do transcranial Doppler. So these things we may not do to such an extent without the research projects. And of course, name and fame and networking. So you get to know people through your research. And now, obviously, if you're looking at an academic job, it is the benchmark for promotions and for jobs. So it is like a publish or perish environment, although it shouldn't be. And then it can generate funding for you to do better work in a way, in an indirect way, provide better care to your patients utilizing this funding. And of course, you can travel, to present the results of your research, which was a major attraction for me at one point of time. Yeah. So, and then there are intangible benefits. So intangible benefits, I think research, being involved in research and writing helps one understand and analyze evidence better. You pick up skills in literature search, in critical review, in your language and expression. It is actually a driver, and it sort of satiates your curiosity. So we are all curious people. We want to know, as doctors, we want to know why does this happen to this patient, why not to the other one. So at a level, as a clinician, you're already a researcher, but this is just putting it into a broader level. So it can help you create solutions to your clinical dilemmas. And there is a joy of discovery in research. So sometimes after the point of time, medicine never gets boring because each patient is different. Not, each patient especially in a field like neurology, each patient that walks into you is different. It is like you're facing an exam every day to diagnose them. So it never gets boring. But after a point of time, the treatment, all those there are standard protocols, right? So there is not much room for you to, okay, so if you diagnose this, you do this, you do this, you do this. There is a protocol. But research gives you an opportunity to break from those standard protocols and to push the limits and see what you can do better. And it is a chance to express yourself. And most importantly, I feel it is a lot of fun. So those are the intangible benefits. There are also some risks to writing, which you should be aware. So one is that it's extremely time intensive. If you want to pick it, so I've shown you those papers, most of them, writing would take weeks to months. I mean, not excluding the time that it takes to do the study. And then it will be at least 5 or 6 rounds of revisions would be there among the co-authors. Then it will go to a journal, they will reject. Some review comments may come, you will revise it. So it is, you can say, at least almost 1.5 years to get each paper out. From the time the data is available. So it is a long road of rejection and rejection. I just put my latest rejection for you all to see. So this is the one that I received, I think, last week. So you should get used to these kind of letters. Many thanks for submitting your manuscript. Many editors have discussed, but decision is that it will be better placed elsewhere. So you will be getting this on a regular basis. So nothing to be rejected about it. You have to take it in your stride. If they give you some comments, it's a good opportunity for you to revise and submit again. You should be very welcoming of criticism, not only from reviewers, but also from your co-authors. And a critical co-author or a critical mentor is the best thing you can hope for. But you should be, okay to receive those comments from them, but that is what will make your paper better and your research visibility better, right? So you should be able to welcome the criticism. And it often needs focusing on a particular topic or skills at the risk of neglecting others. So when I was an MD resident, I knew a lot about not only neurology, but also gastroenterology, cardiology. But now I have probably forgotten all of that. Especially clinical, I may need it at a certain level to manage my patients, but not at my research. When you focus, you should have a stream. And those migraine papers followed each other, the tremor papers, the dystonia. So somewhere you need to focus to develop that skill, and for which you may have to sacrifice some of your other skills. So we come to the question, finally the title, which was what is the value of a research paper in your name? So I think you should be asking, the question should be framed a little differently, that what is the value of a research paper in your name to the society? So that should be your question. Because that also in general eventually determines the value of that paper to you, right? So there are path-breaking discoveries always, but not everybody, or only a minority or a supra minority would be able to make path-breaking discoveries. But incremental gains are also important. So as I showed you, even these small things, botulinum toxin has been there for many years, but if we can show that it is helpful in dystonic tremor, then you are helping at least a small percentage of patients who come to you. You may be able to help them. So incremental gains are also important. So we not always hope that, okay, I will work only for the Nobel Prize, but whatever you are able to do to make this world a better place is good enough. So when you talk about the value to the society, we should think about there are many, these are some pitfalls that you may fall into on your journey. So there are a lot of times we do a lot of Me Too papers. So then you find it very difficult eventually to publish them, to get them go to a good place, because the society doesn't see the value in it. The society or your peers who are going to review it don't see the value in it. Then you may we always have to steer clear of any conflicts of interest. Industry may try to influence your research. There is a lot of talk now about ghost writing, and I forgot to now about predatory publishers. So in that, our urge to write and gain visibility and publish more, these are some pitfalls, especially predatory publishers. So many journals you may be also getting in your inbox, so we have to be careful there about the data that you generate, about the papers that you write, and where you choose to publish them. So the value of your paper would definitely be compromised by these. So overall, I think the most important thing that I would like you to take away from this talk is that the most important thing from a clinician scientist perspective is the research question. You should try to spend your time and effort in identifying a question which is worth answering. Then the other things will follow. So it is the clinical experience that generates questions, and this is your strongest strength as a clinician researcher. And answering a research question may generate further research questions, and usually the first one is the toughest. Once you do the first one, then the questions normally pop up on their own. So I would just like to wind up with some resources for budding scientists. So you may be all aware of the ICMR studentships, thesis support from them. This is a great website that is run by the American Academy of Science. And I personally found it very useful. So you can sort of log in and give your details, and it makes you take surveys about identifying your own interests. So even in science, there are many opportunities, right? You can be a bench scientist, you can be a clinical scientist, you can be a science administrator, you can be a science communications person. So where you fit in the spectrum according to your expertise and your interests, this is a website that can guide you. And the most important thing is to find a mentor who can guide you in this exciting journey. So I would like to say thank you. Before saying thank you, all the work that I have shown you would not have been possible with the support of, these are my two mentors, Professor Lal and Professor Asha Kishore, and this is my current mentor, Professor Padma, who's the head of the department at AIIMS, and this is Professor Achal, who is a movement disorder specialist at AIIMS. So they have all been supportive of me throughout my career. This is my small research lab. They are senior research fellows, Ananda Padmanabhan and Aarti, and a junior research fellow, Bhavna. So all the work that you have seen is from the help of these individuals and the patients who choose to take part. And these are all funding agencies and the institutes that I have been associated with. Thank you very much. I'll be happy to take any questions.
Ma'am, hello ma'am.
Yes, yes.
Ma'am, we have a few questions in the chat box. The first one is, can you see the chat box? Should I repeat? Should I give the questions?
Let me see. Where is it? Ah, yeah. Yes, I can see that. Yeah. So dopamine side effects. Is that the first question?
No, ma'am. That was the answer to one question you asked.
Oh, yes. That's right. Yeah, that's correct. Correctly identified. So, first question is, does having a paper in your name give your CV more importance than your peers who don't have one? So definitely it does. I don't know how, whether it is fair or unfair, but as things stand as of now, it definitely does. It depends on what you are aiming at. So if you're aiming at an academic position or an academic job, then all your whatever work you have done, finally your merit is going to be judged by what you publish. So it definitely helps you. So I would like you to, many times it is unfortunately the number of papers that people tend to look at. But I feel it is also important to look at the quality of the work. It may not be about somebody may have 10 papers which are not really anything novel or letters or something like that. But one original article may help you reach there. Depends on the value. So that's where again the value of your question you have answered, the research question comes in there. So definitely having a paper in your CV helps if you're looking at an academic career. There is no second questions about it. So next question is, for a physician come scientist, how good would the MD PhD dual degree be? So this depends on where you are going to, I think, spend your life. So in many parts of the world, like the US, France, UK, nowadays for academic medicine, it is a separate, they may have a separate stream for academic medicine. So and in many parts of those world, to get an academic job as an assistant professor, as a faculty, PhD may be mandatory. In India, so far, it is not like that. So in India, going from a clinical stream to PhD and then coming back to clinics is a little not that easy. So you may have to choose. So if you, in my experience, those who have done PhD tend to become core research people, whereas those who are in the clinical side tend to do more of a clinical degrees and like I have done, do some research on the go. So so if you are interested in core basic science research, as you can see, most of the work that I shared with you is clinical research, so all translational research. But if you want to look at, for example, find a cure for Parkinson's disease, understand the pathophysiology, work core genetics, then an MD PhD degree would be the best way to go. But in opportunities to come back to the clinic after a PhD are a little sometimes, because our clinical degrees are through the entrance system, and so though that integration so far is a little difficult in India, but in the other parts of the world, definitely. Yeah. So PhD programs in research after MBBS, is there any criteria for qualification? Is just so in our, to my knowledge, in AIIMS and IMHANS both run these programs. So both are through an entrance exam. So this is another unfortunate thing in our system as of now, that however much during your training you need a thesis to get that degree, but that doesn't count for your further. For example, somebody who has worked on a neurology or a cardiology project during his MD, it doesn't count towards his chances of getting a cardiology DM seat. So it is similarly for AIIMS, both AIIMS and IMHANS. The PhD programs are through entrance exam. So no other in these two places you can directly do PhD after MBBS. Yes. So how do we assess the quality of a study? Yeah, so that may be a topic that you can take up in your the journal club. So we routinely we have some ways for critical appraisal of a study, right? You may be aware. So if it is a randomized controlled trial, there are certain questions that we ask. Right from the research question, the PICO, you may be familiar with that, right? PICO, the population, the intervention, the comparator, and the outcome, where they chosen appropriately. And then the study design, the randomization, was it done, was it masked, the allocation, was it masked, was there a blinding, and then what are these results? These are for internal validity of the study. And then for external validity, there are some questions, whether the group is similar to patients that you see, and then whether the results are appropriately interpreted, whether the conclusion is appropriately interpreted, whether statistics is done properly. So there are a series of questions that we ask, and this is something we do routinely in our journal club. So when you present a journal club, I'm sure you may be doing that you have these critical appraisal questions, right? So for assessing the quality of that is for a randomized controlled trial, there are these questions. For a cohort study or a diagnostic accuracy study or a meta-analysis, so for each of them there are different approaches to assess the quality. In general, if you talk about evidence-based medicine, at the top of the evidence level would be a very well-conducted, large, appropriately sample-sized RCT or a meta-analysis of RCTs. And then level 2 would be an RCT which is not as well conducted, or maybe sample size is not as good. And then other cohort studies, prospective cohorts. And at the bottom of the pyramid would be your case reports, your experiences, etc. So, but for an individual quality study assessment, there are tools that you can use depending on the type of the study that you're discussing. So one journal rejects you, what would be the next step? So you submit it to another journal. So that should be your next step, and it should be So when you have a paper in mind, right, depending on the value of that paper, you will have some journals in mind. So always, I feel that you always start with something higher than where you expect it to go. So you never know. For example, my DM thesis, I never expected that JNNP would accept it, but I just sent it there, and somehow it got accepted. So so always send it to a higher impact factor journal, and if it goes through, if it comes back as a desk rejection, that means editor rejects it, then you don't gain much out of it. But if it's gone for review, you may gain some good comments. And if it goes for external peer review and you get some comments, then definitely modify your paper according to those comments before submitting it elsewhere. So that will help you. And then you never know. Sometimes some papers, very rarely does it get accepted by the first journal. So you may have to go from, so usually we start in our fields, maybe movement disorder journal or neurology green journal, and then we go to a next lesser impact factor, and then if it comes back, then we look at another lower impact factor options, and then down the road it gets accepted. If it goes for a peer review, it is good for you. Even if it comes back, you will gain some comments by which you can nicely modify your paper and then submit again, and never get rejected by it. This is a part and puzzle of, the first few times it feels really bad, but then you get used to it. Yeah. Then can you suggest a few journals which you have been following in UG periods? Cause in between exams and reading regularly might help us. Yes, definitely you should read. So can you tell me which, you are in your, which year are you all in? Somebody can tell me?
Ma'am, we have a lot of students from each year's final years to first years.
Okay, so so one of the best journals to follow that you would all know is NEJM, right? New England Journal of Medicine. So that has a good spread of all. I think the impact factor is also about 70. That it's not just about the impact factor, but it has all the real path-breaking articles get published there. And then they also have very nice CPC section. If you have seen clinical records of the Massachusetts General Hospital. So though that is a very nice section to follow, because it discusses a small case. Then there is a pathology discussant who would discuss, just like a clinico-pathological conference. So NAJM case records of the MGH is one section you should definitely follow. And they also sometimes have good, very to the point, nice review articles that can help. And then this was one thing, and the other is Lancet. Right, Lancet also has a similar scope. Lancet is a little bit more, sometimes a bit more public health oriented than NEJM, but these two would be good journals for you to follow for a broad spectrum. And then, of course, there are specialty journals. If you feel that you have interest in a particular specialty, you can always choose like Neurology or Lancet Neurology. So all these specialty journals are always there for specific topics or reviews. You can read them. So one good habit is to, if you go to NAJM or JAMA or Lancet, you can always, create an account there, and then they will send you the table of contents every week. So you don't have to go there. It will come to your inbox. You can just skim through. If you see something interesting, you can save it or read it. And that is a very good way to stay up to date. Yeah. Yes.
Thank you, ma'am.
Yes. Thank you. Thank you so much for your attention and taking part so enthusiastically. I'm really impressed with all of you. Yes, I hope you
Thank you, ma'am.
This very well and creates a lot of clinician scientists from all of you all.